Hello everyone. Welcome to the session on enhancing the role of pharmacists in the TB care cascade. I'd encourage all of you to come forward, please, and hopefully that will help us to generate a bit of a discussion afterwards. Thank you. So without further ado, I think we'll start the session. It is my great pleasure to introduce Professor Pai, who is my mentor and a leading expert in global diagnostics, and he's now looking at what pharmacies can do in the field of TB and in the cascade of TB care. His presentation is going to be talking a little bit about the various roles that we play, and I say we because I'm a pharmacist as well, and so I'm very proud to be a part of this session. Dr. Pai is a professor of epidemiology and the Canada Research Chair in Global Health and Epidemiology at McGill University. He's also director of the Global Health Programs at McGill University and as co-associate director of the McGill International TB Center, and brings a range of expertise that we're excited to hear about. Thank you.
Do you have the clicker? Good afternoon, everyone. I'm happy to welcome you to this session on pharmacies and TB care and control. My job is to set the stage on what the field is currently looking like, and then the subsequent speakers, I hope, will build on it and give some positive examples of how this field has evolved. I have no financial or industry relationships to disclose. The first important point I want to make is I want to position where pharmacies and pharmacists fit into the big scheme of things. This is a supplement coming out in Journal of Infectious Diseases this week. Actually, it's probably coming out on Friday night, but I already have the supplement with me. This is a patient pathways analysis done in 13 countries around the world. And what is stunning about this, and it certainly has made a big impact on the Gates Foundation and other main global leaders, is this part. Where do patients begin their care seeking in the cascade of care? And it is striking that 21% go to informal sector, and another 30+%, 39% go to the private sector, and the remaining start off in the government sector or the public sector. So if you add these two up, 1 in 3 people begin their care-seeking pathway outside of what we consider the DOTS program. And if we do not understand this important patient pathway preference issue, we will never get to the bottom of TB. The second important point, and I think this comes from a slide deck that Guy Stallworthy here has put together, is that missing patients are mostly in that non-NTP sector. We talk about 4 million missing people. I would bet in many countries that these people are not quietly dying at home of TB. They are seeking care, but they're going to a segment that is invisible to us, either because we don't care about that segment, or we don't know about that segment, or we've not engaged that segment. Surely, somebody will not quietly die of TB at home. Surely they would have gone to a local drug seller. Surely they would have gone to their local faith healer. Somebody would have been contacted, and care would have been sought. Just because we don't know who they are or what they're doing doesn't mean that care seeking is not happening. And I think it is a mistake to think that all of these people are quietly sitting at home, coughing away and not doing anything about it. That this pathway analysis does show they are actively seeking care, just not in the place that we would like them to seek care. So missing patients, huge number of them, actually are in the countries with the biggest private sectors, and private sector does involve pharmacists in a huge proportion. Okay, so let's talk about pharmacies. In many of these countries that we talk about, the highest burden countries, pharmacies are often the first point of care for anything. Doesn't matter whether you have a pain or a leg ache or a headache or a diarrhea, that's where people go first, because it is so easy, so cheap, and practically costs nothing. There is no consultation fee. You just walk in, immediately walk out with the medications you want, you get rapid relief. And the poorest of poor people prefer this because they cannot afford to go to a qualified doctor. And the that's what the data show, that in many, many countries, nearly a third to even half of all patients with TB symptoms first knock on the doors of pharmacists before even going up the value chain to other areas. And there's a whole reasons why. Amrita and I have a paper in Journal of Epi and Global Health where we've discussed this in greater detail. This is a very nice systematic review by Rosalind Miller from London School. I'm really impressed with her work. She's finishing her PhD. So she's published this on how well retail pharmacies do as a whole. And her conclusion is, and I will show you data to back her conclusion actually, pharmacy practice in Asia is characterized by insufficient history taking, lack of appropriate patient referral, poor adherence to treatment guidelines, inappropriate supply of medicines, and insufficient counseling. And that's basically hitting at everything we know to be true with tuberculosis care seeking in pharmacists. And here is the data. We now have several studies on what happens when people with TB or TB symptoms seek care, and that's exactly in line with what Rosalind showed in her systematic review. The most dramatic results, I think, come from simulated patient work. So in India, Srinath will talk more about the paper that he published in Lancet ID. This is Rosalind Miller's paper, came out in BMJ Global Health last month. These are the first two simulated patients for TB in India, where we had trained patient actors walking into pharmacies in 4 cities in India between the two studies, all with the identical case presentation with some slight variations. If you send someone and say, I have cough for a long period of time that's not going away, correct management, which is either referral, which is mostly all referral actually, will be not giving antibiotics. Okay, correct management is referral, and not giving inappropriate antibiotics is so low. It's 13%, right? Referral is so low. This is our case, and antibiotics are extremely widespread, right? And Schedule H1 drugs, which is restricted list, is used a little bit, but most impressively, not one pharmacist in 4 cities gave away any anti-TB medications first line. So that to me was a very interesting and important finding. So the question is, pharmacists are not just drug dispensers. They could be doing many other things as well. This is again from Amrita's paper. Currently they're doing drug dispensing, but they could be triaging and referring. They could be counseling patients. They could be supporting with drug sales surveillance, and so on and so forth. And the question is, how effective are the interventions when pharmacists are engaged? I don't know why this is jumping so quickly. Maybe it's too sensitive. So we did a systematic review led by Amrita and Daniel in my team. We've now searched a large number of studies, and we looked for interventions that went beyond just drug dispensing. And we stuck to global literature in English. These were the databases searched. I won't go through all of the detail. We're writing this up for a publication right now. And in the end, after doing all of the searching, Amrita and our team found 18 studies. The methods are all over the place. No two pharmacy intervention looks the same. Everybody has done their own thing to engage pharmacists and intervene, which I think kind of makes sense. It's all context dependent. So we're not doing a meta-analysis. We cannot pool the results, but we are narratively trying to synthesize the results. So these are broadly the buckets into which the pharmacy interventions fell. The first is, any pharmacist who sees someone with suspected TB should refer, which is the old-fashioned normal way of engaging pharmacists and private sector. Secondly, using pharmacists to improve TB treatment adherence as DOTS providers and counselors. And there are a bunch of studies in high-income countries which are either focused on using pharmacists for latent TB testing or latent TB adherence support. And here are the results very broadly. I'll focus more on the low-income countries because that's what I think we are here for. I'll ignore the LTBI part. We only found about 7 studies that looked at the referral of pharmacists, and here the goal was getting pharmacists to refer symptomatic people to clinics, mostly in Asia, some in Africa and South America. And here is the main punchline. Pharmacy participation was low in general, and we will show you more data on that in a second. But once you engage them, those who do agree to work with you, the yield among them is reasonable. So pharmacy participation is not that great, but once you somehow engage them, the ones who work with you do tend to refer patients to you. The second is all about adherence support. And here again, you can show that in these 5 studies, there was improved adherence to medications, clinic visits, and sputum conversion, but they also identified a whole bunch of barriers in all of these studies. So not a lot of literature that are telling us how good pharmacy interventions are, and most importantly, there does seem to be a signal that you can work with pharmacists, improve screening, improve referral and adherence, but very limited data on scalability and impact, which I think is a generic problem in PPM, that we are pretty good at these small pilots, but very few PPM projects we know have reached scale, certainly not to an extent that makes a huge impact on the country's notification or outcomes. So the same problem is kind of recurrent in the pharmacist literature. This is work by Niranjan, who's sitting there on the left side, where he wrote a very interesting piece on, and I'll ask him during Q&A time to walk us through this very interesting graphic. But essentially the punchline of his analysis was, after 10 years worth of PPM work, we're just not successfully tapping pharmacists. It is a huge untapped potential in the world of TB, that there are hundreds and thousands of pharmacies, and we're barely touching a reasonable number of them, and the notifications from them overall continues to be very low, which I think is the main essence of his work. So the last few slides are from Guy Stallworthy here, who's done a very nice analysis of private sector engagement. And I think what could be some of the potential ways to overcome this very weak, anemic response we have with this massive numbers of pharmacies that we know exists. So firstly, as Guy says, private sector engagement itself needs to be prioritized by governments. If governments and NTPs don't care about private sector at all, then pharmacists will not be engaged. Secondly, the prioritization needs to come with funding as well. You just cannot engage pharmacists without putting in any money. We've done work, and Ramya has done work. Anyone who's done work with pharmacists know that it costs money to go around and network them, to educate them, to incentivize them. You got to put money down if you want to get something out of it. Secondly, we need to better understand how private health markets, in particular, what is the business model of a pharmacist. They're all entrepreneurs. Many of them have zero training in pharmacy. They're just business people running a business. And to go to them and say, refer everyone, has never worked, right? And I don't think it will work, because it completely flies against the economics of how retail pharmacists work. So without understanding how they think and what drives them, what motivates them, we're not going to get them engaged at scale. And there are regulations. You saw here, to me it was a striking finding that not one pharmacist in 4 Indian cities gave away anti-TB medications. Until we did the simulated patient work, everyone in India used to say, oh, it's these pharmacists in India who are generating drug resistance by giving away anti-TB medications like candies. Turns out not one of them do. So which means regulations in some way are working. And we need to know what is working and what is not working, and why regulations might work in one city, may not work in another city, and tap that potential to get them more engaged. And as Guy says, we need a cadre of implementers and technical assistance provider who totally get private sector engagement. And last slide, it seems to help to have an intermediary agency which goes and aggregates pharmacists and networks them and brings them all into the fold and educates them and monitors them. And certainly this has been a good experience from India in the last few years. Government funding, contracting, provision of free drugs. So can you have the local pharmacist give away a government FDC product? The answer is yes, but you need to figure out how to get them to give away a government FDC so that the patient benefits from free drugs. ICT system seems to be a fantastic force multiplier. If you can pay your pharmacist their incentives with a mobile phone, rather than say money is coming and the money arrives 1 year later, that is the easiest way to lose them. Rapid payment of incentives is one good way to keep them, because they are all entrepreneurs. They will not wait for 1 year for your money to come. And that seems to improve notification, adherence monitoring, so on and so forth. And lastly, providing public goods through private pharmacies is one way to making sure patients are protected from catastrophic costs, and that certainly helps linkages between public and private. So with that, I'll stop and thank all of these people who've really done very interesting work in the area of pharmacists and PPM. Thank you. Questions are here?
Yeah, thank you, Amrita. I think Madhu has already mentioned that we've done a pharmacy standardized patient study to understand the practices of the pharmacy. So I'm going to elaborate a bit more on that study and describe the nuances of some of the findings that we found in that study. So I have no conflict of interest to declare. So this study was published in the Lancet Infectious Diseases, and I'm going to elaborate a bit more on that. So the research question that we had for this study is that what do Indian pharmacies do when they encounter patients with presumed TB or known TB? So this was a research question that we had, and specifically we wanted to know, to assess what proportion of the pharmacies refer such patients to healthcare providers or dispense antibiotics and or steroids. So these were the two research questions that we had. So as you know, standardized patients are normal non-diseased individuals who are from the local community who are trained to enact certain tracer medical conditions, and after training they go to the healthcare providers or pharmacies and present themselves as though any other normal patient would present, without the providers or the pharmacies knowing that these are standardized patients. And based on the care and advice that they receive from the pharmacies, they come back and within half an hour debrief on a structured questionnaire on what were the types of questions they were asked, what were the type of medicines that they were dispensed, and and various other contents of the interaction. Based on that, we get to infer what happens to the patients when they present to pharmacies in normal practice. So we had validated this methodology in India. So we had used 4 TB tracer conditions. So these are the 4 conditions that we had, and this methodology was found to be acceptable on all the parameters that we had used for validation. So 2 of these cases, from 2 out of these 4 cases, we had used in our pharmacy study. So we had 2 standardized patients. The first patient was a person presenting with cough of 2 weeks or more, and in case if the pharmacist asks, do you have anything else other than that? Then if the pharmacy asks, for example, do you have fever, they would say yes. If you have night sweats, they would say yes. If you have loss of weight, they would say yes. So all the classical textbook symptoms of tuberculosis the patient would have, but the presenting symptom would be, I'm having cough. Can you give me some medicine for that? Okay, so that's the presenting symptom. So this is the first case who is a TB symptomatic, a classic textbook case of a TB symptomatic. And the second case, what we did is that the same person, but he carries a sputum smear positive report indicating a TB case. So which means that he says that I was having cough, I went to a healthcare facility, a public health facility, they asked me to undergo sputum examination. I've undergone the sputum examination, and this is the report that the laboratory has given, and it clearly indicates that there is a sputum smear positive report. Okay, so this case is a classic case of a TB patient. So the expected ideal management for both the cases is referral to a healthcare provider and no antibiotics or no steroids. So this is what we had. So we had sent our standardized patients to 623 pharmacies in 3 cities, Delhi, Mumbai and Patna. So each of the pharmacies in Delhi received both case 1 followed by a certain duration of time with case 2. Okay, so we had a direct head-to-head comparison with respect to what the pharmacist did when he was presented with a person suspected of tuberculosis vis-a-vis a case of tuberculosis. So this was the methodology that was adopted. So each pharmacy was visited by both case 1 and case 2, though we had 623 pharmacies. Now 599 case 1 presentations were completed and 601 case 2 presentations were completed. So some of the pharmacists could not be contacted because either they were shut down or they were not available when the standardized patient made visit. So that's the reason why we couldn't have all the 623 pharmacies visited by both of them. But at least 88% of the pharmacies had both first case as well as the second case visited. Yeah. So The studies, the three cities, one was in North India, the other one is in East India, and the one in West India, Mumbai. So we had a fairly, three large urban cities covered under this study in three different parts. So the results. So general, when the patients presented to the pharmacies, the interaction between the pharmacy and the standardized patient, on an average it took about 1 to 2 minutes. The pharmacist usually asked 1 to 2 questions, and then there was some kind of medical drug dispensing that happened, and the standardized patient on an average paid about 40 to 60 rupees, Indian rupees, during this transaction, which is approximately equal to $1 United States dollar. So the case 1, when 599 pharmacies when the case 1 visited, so these were the results. So 96 pharmacies referred them to healthcare provider. In addition to referring, they dispensed antibiotics and steroids. 16 of them, they dispensed antibiotics or steroids. No antibiotics or steroids by 80 pharmacies. Okay. So whereas 84% did not refer the patient suspected of tuberculosis to a pharmacy. So when they did not refer, 227 out of them gave antibiotics and steroids, and the remaining 276 gave no antibiotics or steroids. So 505, whereas 84% of the interaction, some medicines were dispensed to the standardized patients. No first-line anti-TB drugs were dispensed in any of these interactions, and fluoroquinolone antibiotics was used in 10% of the cases. So the expected ideal management that we had said is referral to a healthcare provider with no antibiotics or steroids. This happened in 80 out of the 599 interactions, which is approximately 13%. Okay, so this is case 1. Now the case 2, the same set of pharmacies when they were presented with case 2. So this is what happened. So 601 pharmacies interactions, referral to healthcare provider, this was 67% here. Did not refer to healthcare provider, 33. So this is a classic case of tuberculosis with a sputum smear positive report. So antibiotics and steroids were given in 29 pharmacies, no antibiotics or steroids in 372 cases. So the expected, no first-line anti-TB drugs were given even for these cases, and fluoroquinolone antibiotics were used in 4% of the cases. In fact, we had expected that fluoroquinolone antibiotics may be prescribed in a higher proportion when compared to the previous case, whereas here, lesser number of standardized patients were dispensed fluoroquinolone antibiotics. Therefore, the ideal management, that is referral to a healthcare provider without any antibiotics or steroids, occurred in 372 of the 601 case 2 interactions. That is 62%. Okay. So here is a head-to-head comparison. The same set of pharmacists, when they see a presumptive TB case, this is the management. Ideal management is 13%, whereas here, when they see a case of tuberculosis, it is 62%. Referral, it's more. Antibiotic usage decreases. Steroid usage decreases. Fluoroquinolone usage decreases. Schedule H and H1 drugs, these are prescription-only drugs to be used in India. So their usage also decreases considerably. And no first-line anti-TB drugs. So the adjusted odds of ideal management, case 2 versus case 1, is approximately 21. So which means that the pharmacy dispensing practice is sensitive to the information that the standardized patients present to the pharmacy. So if they are presented with more information, and if it indicates some underlying severe disease, then they are much more likely to refer the patient to a healthcare provider rather than try out all combinations of antibiotics or anything. So this was a very important finding for us, because we had expected that this case would be given more antibiotics, more drugs when compared to this, but on the contrary, the reverse was happening. So this is the 3-city, how they fared. So I'm just going to focus on ideal case management. There was a lot of variation. So Delhi, ideal management was much higher, relatively much higher than in Mumbai and Patna. Antibiotic and steroid dispensing, in Mumbai it was the least, followed by Patna it was highest, and Delhi it was moderate. But the most important thing is that nobody gave out anti-TB medicines. So these are the types of medicines that were given out. Okay, we've listed all the medicines. Among antibiotics, the most common was amoxicillin, followed by ofloxacin, ciprofloxacin, azithromycin. Paracetamol was also given, then chlorpheniramine. So we've listed all these drugs that were dispensed during the, and these are all labeled drugs. So there were some unlabeled drugs, if they are dispensed, then we haven't included here because we couldn't analyze the content of those medicines, unlabeled medicines that was dispensed. So this is only of the labeled medicines that was dispensed. The type of medicines described for case 2 was almost similar to what was described for case 1, except that a lesser proportion of pharmacies dispensed the medicines. In addition to the information that the pharmacies are presented with, that we know that the pharmacy dispensing behavior is entirely dependent on that. In addition to that, we also noticed that internally, if the pharmacist decides to refer, so if the pharmacist decides to refer, then his practices are entirely different versus when he decides not to refer. So if he decides not to refer, irrespective of whether it is case 1 or case 2, they will try out all combinations of medicines. But in case if they decide to refer, then as you can see, the number who are not prescribed any medication, it increases. So that is another thing. So whether the decision to refer, if they make a decision to refer, then they are not unlikely to dispense any medicines. So this was another finding. So then I think Madhu already alluded to this study, which was done. Here the standardized patient that they used in this study, which was published in BMJ Global Health, is that the same case, but instead of carrying a sputum from a positive report, the patient says, we have had a relative staying with us who had TB. So that was the information that this standardized patient gave out in this study. And I think Madhu already shared this, so the results are more or less compared. And we believe that the BMJ Global Health standardized patient was somewhere between our case 1 and case 2. The information that they provided to the healthcare providers was between these two things, and therefore this is the practices that were noticed. So what are the implications of this study? One is the practices of pharmacy is dependent on the information that they are presented with. So this was one of the important implications. Antibiotics, including fluoroquinolone use, is common despite clear policies, Government of India policies that prohibit their over-the-counter use. But pharmacies do not abuse first-line anti-TB drugs, and hopefully this extends to all the newer anti-TB drugs that are coming out in the market. Pharmacy OTC practices likely cause diagnostic delays in our setting, but unlikely to generate resistance to first-line anti-TB drugs because they are not dispensing anti-TB drugs. And then, lastly, overall, there is a need to engage pharmacies to improve antibiotic stewardship. So thank you.
Thank you very much. Excellent presentations. I'm Guy Stolber, the Gates Foundation consultant, so I have a couple of points. One, it's very interesting the finding that they didn't spontaneously dispense TB drugs. But in none of these cases, if I've understood correctly, did your standardized patient go up and say, could you sell me some TB drugs?
Yeah, no.
So I think we all know that in India, very many of them would have done so, because I've purchased TB drugs in India. So I think that's an important caveat to the finding that they're not giving out lots of TB drugs. They may well be without prescription if people ask for them. And then a question was in the issue about the chain pharmacies. Did they find any different behavior with the chain pharmacies? Because many of us have hopes that this kind of consolidation could lead to better TB.
So in our study, we did not disaggregate between chain pharmacists and individual retail pharmacists, but in the Bangalore study, they did disaggregate and they did find some differences in that. Yeah, better in chain pharmacies,
Hi, so I think this is very important, pieces of the study, but I think Madhu, you should also do a study, because in India we know, observe, that even though the license is required, for that you have to be B-Pharma. But how many of your pharmacies, they were having a actually qualified person? Usually, if you go, the license is there, but 10th pass, or not very 6th or 8th person, he is dispensing the medicine. So it will matter a lot. If at that particular time, if you ask the qualification of that person, then if it is actually pharmacist, he might do what you are case to salary. But if it not actually the pharmacist on that time, your salary will be case 1 life.
So yes, I agree that, we could not assess who they interacted when they visited the pharmacy store, whether it was a person who was qualified B-Pharma or whether they interacted with some boy who was responsible for dispersing medicines. So that's one of the limitations of the study, and that could, influence.
No, the thing is, we know vast majority of Indian pharmacies are never run by trained pharmacists. That's plenty of data, so that could also be.
That data has to be there, I know, everybody knows here from India, but in the globally, it is, I need this kind of published information, this is not there.
William Miles from USA, Srinath, lovely study, and I'm a big fan of your work. Just a methodological question, you have your scripts, you go through them. I'm just wondering, how do you control for the kind of drama of the individual person doing the script? So if they come in and are very dramatic and say the same words, but really like, oh, I'm so sick, then maybe they're more likely to get given drugs. Whereas if they come in and they're very calm, they may just be given cough drops and sent away and not referred because they seem like it's not a big deal to them. So how do you control that?
Yeah, so basically, number one, there's a lot of anthropological observation happens before standardized patient study scripts are written up. We have anthropologists in our team who visit and see how the normal patients present themselves to the pharmacies, and this is whatever presentation is seen is an average presentation. That's number one. So how we design the script. Okay, it's based on observation. Second thing is there is almost 135-hour training that each of the standardized patient undergoes, where his acting is made consistent across all the pharmacies. How much he should act, how much he should not overact. All these factors are taken into consideration and are told him, so that he should not get detected that he is a fake patient or something. Because that is also an important. If he gets detected as a fake patient, or if he does not pass off as a normal patient, then the methodology could get invalidated, because that would not reflect what an ideal patient would receive under real life conditions. So the training is there, and then of course there is some distant observation that happens during the process of interaction to see whether they are performing as per the script or not. Yeah.
Related to that, I think that will be also very important information. If you can correct, I don't know whether it was corrected or not. If the actor behaved like a rural background, illiterate person, or sometimes or literate, speaking in English, I have this symptom smear report, can you give some medicine, or he will speak in local language.
Yeah. So
a very nice study. But I'm wondering, was this followed by a kind of intervention study to change the behavior of those pharmacists?
yeah, so it's coming.
Coming.
Yeah.
Thanks, Rina.
Thanks a lot.
Thanks, Amrita. Good afternoon, everyone. It is a great privilege, and I'm grateful for the opportunity to present to you this afternoon our experiences with the use of SMS to improve TB retreatment success in the IMPRESS study conducted in Durban, South Africa. Okay, a brief overview of what my presentation will cover. We'll have an introduction on the use of SMS, short messaging service intervention, how it was used in the CAPRISA 011 study, improving retreatment success, the IMPRESS study, the methods used to incorporate SMS intervention, how we went about designing SMS campaigns, how we incorporated this into the clinic flow and also into the pharmacy processes amongst the roles and responsibilities of the pharmacist, and go through the findings of our use of SMS within the IMPRESS study in terms of operational challenges, acceptability, SMS content, a little bit of what we've discovered in terms of access to basic versus a feature or smartphone, and lessons learned in terms of ethics and other design considerations. Okay, so it's well known that the use of mobile technology in resource-limited settings is rapidly increasing, and cell phone-based interventions have been shown to have great potential for use in healthcare. In South Africa, within South Africa, cell phone networks are very well developed, with countrywide use to be estimated at approximately close to 60 million, with almost 117.6 per 100 inhabitants in South Africa having ownership of a cell phone or access to a cell phone. So by mid-2013, the statistics reported in our country, with a population of 54 million, there were approximately 68 million active mobile subscriptions. So more than 1.6 active SIM cards per person inhabiting South Africa. Okay. Text messaging, or SMS, in various clinical trial settings have already been shown to be both cost-effective and inexpensive with immediate results seen. It can serve as a potential tool for behavior modification in disease prevention and can improve both self-reported adherence as well as viral load suppression rates, as seen in a randomized clinical control trial conducted by Amasari et al. We also see that there's no special skills required to receive, understand, and interpret a text message. Lester et al., in their randomized clinical trial conducted in Kenya, also reported that there were no direct results in any adverse effects, for example, injury, breach of confidentiality, or other social harms reported for the recipients of the SMSs. Also, it is well known and also has been well reported at the union meeting this year, the use of cell phone and other mobile-based technologies in DOTS, or directly observed treatment, to support and to promote drug compliance during TB treatment. I'd like to bring your attention of particular relevance to this presentation, a presentation by Richard Lester at the a session on Wednesday morning detailing the evidence of the impact of digital technologies when used for TB medication adherence. So the slides are already available on the conference app, so please do go and look at the evidence that's been presented on the use of SMS. Okay, just a little bit of background in terms of the study in which we used SMS. The CAPRISA IMPRESS study was an open-label, randomized, controlled clinical trial comparing two regimens, two 24-week oral regimens, one with moxifloxacin in comparison to our standard 24-month tuberculosis regimen. So we used for smear-positive pulmonary TB in patients who were previously treated for TB. The study ran from November 2013 up until study closeout this year in July. And we conducted an ancillary study called Communicate, based on the bulk SMS system that we used to administer the SMSs. And it fell under the ancillary objectives of the IMPRESS study as follows: to assess acceptability and feasibility of the SMS reminders amongst the study participants who had recurrent TB in our clinical trial urban setting, and also using computerized dispensing to generate various reports such as missed visits and other data that would be combined with the use of cell phone technology, basically SMS, to assist with monitoring patient adherence, tracking, and retention. The methods used to facilitate implementation of SMS use within IMPRESS, we developed SMS content in both in English as well as isiZulu, so that the participants would be offered a choice of their language preference in which to receive the SMS, timing and frequency of the SMS delivery, and also the content of the SMS was included in the informed consent of the study. So the content was approved by the ethics committee. We set up a bulk SMS system known as Communicate, where we had to have enough credits to administer these SMS campaigns, and also we had routine technical support provided by the service provider or the developers of the Communicate software, also locally based in Cape Town in South Africa. designed data collection tools which were used to schedule daily SMS campaigns in terms of collecting information in who needed to get an SMS, what the next appointment date would be in relation to what type of SMS they should receive, and when they should receive it. We also drew up checklists. I'd call it checklists and or questionnaires because the document contained also certain triggers or flags or points what to do if there was a certain occurrence, for example, a change in a cell phone number, change in language preference, etc., or any change in the treatment that would directly affect the scheduling of the SMS or the content of the SMS to be received. We also then trained the pharmacy staff in terms of using the bulk SMS system, how to administer these checklists, which were done during face-to-face interviews during the pharmacy consult. And we also trained the rest of the clinic study staff who would administer the informed consent, so they'd be aware of what the study SMS content would be and how to engage with participants when they were conducting informed consent with them. In the IMPRESS study, we had 197 participants enrolled, of whom we approached 195. Two were deceased before the SMS study could be implemented. Of this cohort, 181, so 91.8%, consented to receive the SMS, and 7.2% did not consent to receive the SMS for various reasons listed on this flow diagram. Some of the examples here, they did not need SMS reminders, they did not use SMS, 2 participants did not have a cell phone, 2 refused to receive SMS by virtue of the fact that they were sharing cell phones with either friends or family, and 1 participant refused due to being illiterate. Okay, an example, these are the 4 SMS campaigns that we conducted in the study. Let's see if this works. Okay. We set up a motivation SMS with this message to go out at 3 time points in the study. So we use this as a test message on the day of enrollment as well. Oops, it is very sensitive. Sorry about that. Okay, so the motivation SMS was sent out at 3 time points within 1 week of starting their TB treatment. At the end and at the beginning, with 1 week, then 1 month into this taking their TB treatment, at the end of the intensive phase, so that was within 2 months, and with them starting the continuation phase. So those were the 3 time points. After 1 week, 1 month, and then at the start of the continuation phase. The PK instruction SMS, we had another sub-ancillary study there where we're looking at the pharmacokinetics of moxifloxacin as well as rifampicin under different objectives in the study. And so we provided instructions, please do not take your TB medication the night before or the night or the morning before coming to the clinic. Carry your TB drugs with you to be taken at the clinic. So to ensure that these instructions were followed and the PK visit could be conducted adequately. We also sent out appointment reminders, specifically 3 days before when a patient was expected at the clinic, and a missed appointment visit. So if a patient missed their visit or they defaulted their visit, this SMS was sent through. I'm not going to spend much time on these slides, but this was basically to demonstrate how we were able to fit in or incorporate SMS use into the general study procedures here. You'd see there were 2 visits to pharmacy. So at the 1 time point, we do a pill count that was used to do an adherence assessment of their TB or ARV treatment. We had a mixed cohort. So some patients were HIV negative, some were co-infected, HIV and TB. We also use this to provide adherence or refer them into our adherence support program or ASP. So there was a lot of inter-referrals there. We also conducted our SMS acceptability at that time when we conducted the pill counts. So we conducted that interview, used those checklists. Also, due to regulations, offered them the opportunity to opt out of receiving the SMS if they so wished to, and we also checked that their cell phone numbers were still active or had not changed, so we'd be able to continue to successfully send out SMSs through to them. And then when they do come back to pharmacy, we'd continue dispensing treatment to them. Okay. In terms of roles and responsibilities, it was easy to integrate it into the current setup of what is expected from a research pharmacist within the IMPRESS study. And just to point out, in terms of daily SMS scheduling, by having an appointment-based review of who was expected on the day and who did not present for the visits, we could actively track and help to aid retention in a study by tracking who did not come through for their visits and schedule that default or missed visit SMS accordingly on a daily basis. I'm just going to go through these slides quickly for the essence of time. Operational findings, in terms of opting out from the system, it was 1.7%. Language preference for the native language Zulu was 71. We had a 7% SMS failure rate, where the online dashboard for the SMS allowed us to see the status of the SMS delivery, whether it was pending, received, or delivery failed. Some of the common reasons for failure, so when patients came back during the interview, we were able to determine whether their reasons. A lot of them reported network issues. They would remove their SIM cards from phones. So at the time when the SMS was expected, that card was not in the phone, and so the SMS delivery failed, or the cell phone number changed in that time frame within which we anticipated them to receive the SMS. About 8% of our patients reported sharing phones amongst friends, family, and neighbors. So here, operationally, it's very significant when you're looking at the potential for social harm or unintentional disclosure, etc. In terms of overall retention, in those that received SMS, retention was 96%. The group that did not receive SMS, retention was 89%. Acceptability, we had 92% uptake. Reasons for refusal, we've looked a bit at that. Not having a cell phone, sharing cell phones, didn't need SMS reminders, illiterate, and cell phone number changes was very significant, where 28% had changed their cell phone numbers. In terms of acceptability questions, just to generally summarize, the content of the SMS was highly acceptable. Patients found it easy to understand. They were willing to receive information on their condition and reminders for the SMSs. So these are the questions we use to assess acceptability. This is just a graphical representation of what I've already discussed. The only new thing maybe would be in terms of timing, preference of the SMS. Majority, 54% preferred evening, so 5 p.m. onwards. In terms of type of the reminder method, 95% of them preferred SMS. So SMS is very commonly used in comparison to social media, where only 24.8% indicated that they prefer a reminder using that method. And this is general, just in our setting, in terms of getting access. If you had to look at whether using a basic phone, example SMS, that's accessible on all phones, or going the app way, using something that you need a smart or a feature phone to use, we could tell that from the sample, only less than 40% had a phone with sorry, I'm saying it the wrong way. 40% had a basic phone. So if you're going to use a smartphone app, you're going to lose, or you won't be able to access, the intervention will not be, you won't be able to provide an intervention to this percentage of your population. And looking at age, factor that in. Those who knew how to use the SMS or had knowledge on how to use internet, you're looking at the older versus younger generation, so taking that into consideration as well. When you're designing interventions or apps, it's nice to have a package, so something tailored to the younger generation, also for the older generation, maybe tying in training with that. Ethical considerations in terms of content, time of SMSs following your local regulations. And to conclude, what we found that the use of SMS and the content was using content that is accessible on any basic phone was acceptable for both the patients and the pharmacy providers. And pharmacists can be strategically utilized to provide these types of mHealth interventions to patients. And the use of SMS to educate patients, promote adherence, continues to show great value in the TB care cascade. Thank you.
Maybe we can just hold questions for the end. I'm going to, in the interest of time, ask Dr. Ramya to come forward. Is that okay? Thank you. So it's with great pleasure I'll introduce Dr. Ramya Ananthakrishnan to present on her terrific work with private pharmacies in South India. Ramya is the executive director.
Thank you, Amrita. I'd like to thank Dr. Madhu and Amrita for giving me this opportunity to present on engaging the private pharmacists for TB control in Chennai. And unlike, I think, the previous 3 presentations, I'm going to be sharing the experience in implementation of the pharmacy engagement over the last 4 years. I have no conflict of interest. Just to give a brief mandate, so I work in REACH, which is a non-governmental organization working for TB control for the last 18 years, and we work primarily with the private sector. We also provide patient care and support, and we do capacity building of patients to have a voice in the community. We also work in strengthening communities both at the urban and at the rural levels, and we also work with the advocacy initiatives, and currently we also are implementing the USAID's call to action in 6 states in the country of India. So before I start the presentation, I'd just like to narrate an incident of one Mr. Raj, who is actually an 18-year-old undergraduate student who was actually having symptoms of TB, and he was very sick, and he was going to private practitioners, in fact several private practitioners, and getting medicines like antibiotics. And he was so sick that he actually discontinued his studies. He refused to go to the college, and he in fact feared that he might even die. And that's when a pharmacist, on speaking with his parent, his father, and when he understood the symptoms of his son, he actually referred them through the REACH initiative to the government, where he was diagnosed with TB. And then subsequently he was started on treatment, and he became well, and after 2 months he actually rejoined college. So I think I just narrated this incident to show how important it is to actually engage the private pharmacies in any successful TB control program. So I think this background, I think we'll just skip this. I would like to actually talk about our experiences in implementing a program in the city of Chennai, which has a population of 8.6 million, with over 25% of the population in the slums. And the objective was basically to establish a sustainable partnership for TB control with the private pharmacies in Chennai, and to encourage referrals from the private pharmacies, to also promote awareness on TB and DOT through the private pharmacies to the patients who come for getting drugs, and also to facilitate the pharmacists to act as DOT providers, and also to improve the quality of DOTs in the private sector. In terms of how we actually went about implementing this initiative is, in India, we have very organized associations, the pharmacy associations, and they have several branches, very similar to the medical associations, and they are organized groups of associations having pharmacists, and so we had several meetings with the pharmacy association leaders, and we got the line listing of the pharmacist, and subsequently we developed the communication materials, and we trained the pharmacists both on through workshops and through one-to-one visits. And I think one of the key process which we undertook was revisiting the pharmacists so that they could understand how they could actually participate in the program. And we also participated in the periodic review meetings that these pharmacy associations have among them. And finally, we also provided this whole feedback about the engagement of the pharmacists with the district TB officers and the state TB officers. Just to give you an illustrations of the pharmacy engagement, I think the first we'd just like to stress that the follow-up visits to the pharmacist was a very critical component of the whole pharmacy engagement. And the second slide, as you can see, the communication materials which are displayed in the pharmacist, because we encourage the pharmacist to actually participate in 5 ways. And we coined it the term direct, which basically is direct is D for display, I for inform, R for refer, E for educate, C for counsel, and T for to be a treatment provider. So these were the different ways in which a pharmacist could actually engage in the program. And these were some of the communication materials which were given or stuck in the pharmacy. And for those patients who were actually coming in for TB medications, we encouraged them to give information brochures on how to take daily treatment and how to complete treatment. We also provided them with medicine covers, because one of the things which they use for providing over-the-counter medications is these small covers. So we actually encourage them to use those covers which had messages on TB and the need to get themselves tested for TB if they have cough for more than 2 weeks. And in the last 4 years, we have actually sensitized about 15 associations of 18 associations, nearly 2,100 pharmacists sensitized, and we have received more than 2,500 referrals from these pharmacists, and about 143 of the pharmacists actually act as DOT providers to patients consistently, and about 157 of them so far have actually received, patients have received DOT from the pharmacist. So when you actually look at the total referrals, pharmacists actually refer 2 types of patients. One is those who had symptoms of TB, and second is those who are already diagnosed with TB, because these were the patients who actually came in with buying irregular medicines, or if they wanted actually access to good quality care. So there were 2 groups, and I'm going to be presenting it in 2 different slides. The first one is based on the symptomatics. So nearly 1,793 symptomatics were referred, of which we had, I think, 57% of them underwent testing, and we found nearly 25% of them diagnosed with TB, and except for one who died, all the rest were actually initiated on treatment. In terms of those who did not undergo testing, it's roughly 1/3 of them were not willing, because they were actually encouraged to refer to a government center, and these were patients who actually came to the private pharmacies. So they didn't want to go to the government, so they were not willing to get themselves tested at the government. About another little more than 1/3 were lost to follow-up, because I think, as was mentioned previously, writing is not a strong point for the pharmacist, and sometimes they just, we had a referral coupon, and they just used to tear the referral coupon and give it to the patient, even without writing any name. So in our counterfoil, there was no mechanism for us to actually track the patient to encourage them to undergo testing. And again, another 1/3 had actually undergone some kind of antibiotic treatment or alternate practitioners, and they had become asymptomatic when we were following them up. So we couldn't get them back to testing. So this is about the symptomatics who got referred from the pharmacist. The other group is the patients who were already diagnosed with TB. And here we actually, when they are already diagnosed with TB, we do a diagnostic workup with the program, which means if they had been just diagnosed, they would undergo the regular smear examination or X-ray with the program. Or if they are maybe, let's say, in the second month or the third month or the fourth month, they would be examined by the doctor at any one of the tuberculosis units. And here we actually found that 90% of them had to actually had TB and they were initiated on treatment, and about 10% of them were actually declared as non-TB. Another 10% of the patients who were already diagnosed with TB actually did not undergo the diagnostic workup. Again, the reasons are because, again, roughly 1/3 of them not willing, 1/3 lost to follow-up, and another 1/3 actually had already completed 5 to 5.5 months treatment, and it was felt that it was not necessary to actually take the remaining 1 month or so. So this is the kind of referrals that we actually get in field conditions, both referrals, symptomatics, as well as those who have TB. So if you actually look at the year-wise referral, it has been increasing, and I think this is one of the instances, because we have been working consistently with a pharmacist from 2013, and of course 2017 are estimated numbers, and the actual numbers have been mentioned in the box. But as you can see, the upward graph shows very promising results in terms of the whole referral mechanism, both in terms of the number of patients referred or number of symptomatics referred, and and I'll be talking a little bit more on this. Again, year-wise engagement of pharmacists has been increasing, and the last 2018 is till August 2017. So we are quite happy to know that there is again an upward trend in the year-wise engagement of pharmacists. And if you look at the number of referrals by pharmacists, and I think as was mentioned by the previous speaker, most of them actually referred less than 5 referrals, and we have only about 15 of them who actually referred more than 21 referrals. We also did an assessment of the number of pharmacists who actually use the different kinds of communication materials, and I think we found that most of them liked using the medicine covers, which had directions for getting themselves tested for TB. That was the most popular, and followed by the referral coupon and the newsletter. These are some of the testimonials of the pharmacist and the TB survivor, and I tell this because again I think that's something which I'm going to be telling in a little while, that this was not based on incentives. The pharmacist, in his own words, "When we work for a social cause, our standing increases among other pharmacists, and we are able to win the confidence of our customers. Directing symptomatics and the TB patients to quality TB care services has improved our business interests. Participation in TB control efforts is our contribution to public health cause. We are very happy to also motivate our fellow pharmacists in this." A TB survivor has spoken about his experience that my dot provider is a pharmacist, and he ensures that I have privacy while taking the TB medicines and reminds me of the follow-up visits. We are also given the first preference when we go for DOT. So the key strengths of the initiatives has been that we were able to approach the pharmacist in a very structured, organized way through the different zonal pharmacy associations. We've been able to have regular follow-up with the pharmacist by one is a one-to-one visit, and second is participation in the different review meetings. Third is we've also been able to provide access to a TB helpline so that they could call, or their patients could actually call to understand where they could go for appropriate TB diagnostics. Use of the different communication materials. It was a non-incentive based model, and I think unlike one of the previous model, this was purely based on the pharmacist referring, and he or she doesn't receive any incentive. And I think one of the key strengths was that there was a recognition of the participating pharmacists by the state authorities. And I think getting a certificate from the drug controller was very, very prestigious for a pharmacy, not even from RNTCB, but from the drug controller, because I think in the line of hierarchy, he is considered very, very critical, and so that was considered very important. And I think for the first time, we actually facilitated coordination between the departments of drug control and RNTCP program. We're very surprised because these two departments were actually not talking to each other, and so we basically facilitated the whole dialogue. And as you can see, the review meetings, the felicitation, etc. And in terms of key learning, I think there was consistent participation of the pharmacists. So I think there was about 10 to 15% of the pharmacies participating, but it was a consistent participation. There was also direct linkage of the pharmacists with the public program. So now we have the public health workers actually visiting the pharmacists, actually giving the dot boxes to the pharmacists, because they act as dot providers not only to the patients referred from here, but also to patients from the government. So there is now a direct linkage, a line listing was shared with them, and for dot providers, the pharmacists are very commonly used. And again, very convenient to the patients, and all the patients have appreciated that it was much less stigmatizing to take DOT from the pharmacist. And last was, there was also more ownership of the pharmacy initiative by the pharmacist, because I mean, things like when they have their own newsletter, they actually featured information about TB. In fact, there was a pharmacist who actually donated 1,000 tablets of INH when we were actually citing that we had some difficulty in procuring INH drugs, extra 150. So, I mean, there's a lot of ownership, and it's a very closely knit community, and they were happy to help out. And in terms of challenges, again, there was a preference for a one-stop shop. So they don't like to send them here one place for smear, one place for X-ray, and then they come back. So because the patients then give a very negative feedback. So they actually prefer if we could provide all the services in one place. And in the public health program, it is not possible. We did also encourage them to refer to centers called the PPM centers, which is run by REACH, which we had in very limited number. And there was a preference to refer them to the private centers because they felt that that was a value-added services compared to when the patient actually gets directed to a public center. Of course, as previously mentioned, very frequent turnover of staff and recruitment of part-time staff. There is a selection of patients in referrals, and they don't refer all their patients. Only when they feel that they cannot afford, they are referred. Then there is also difficulties when there is the doctor's fees and the participation. That limits coordination. And involving hospital-based pharmacists has also been a challenge, because then we have to go through the pharmacist, and the whole the hospital basically has to be engaged if we have to involve the pharmacist. And so this last slide is what has been the opportunities for us to scale up the pharmacy engagement in TB control. Now in the city level, we have actually launched a very ambitious TB-Free Chennai initiative, which is a flagship program of Chennai Corporation. And the pharmacy engagement is going to be continued, scaled up, and it's going to be a very critical component of the private sector engagement strategy. At the state level, pharmacy engagement and sensitization is being rolled out in 14 districts of Tamil Nadu under Project Akshaya. And at the national level, through the Call to Action initiative, we have actually expanded this model to the states of Bihar, Odisha, Jharkhand, and Assam. And there's been a lot of interest by the state TB officers to adopt this model. And it's a rollout planned as a joint initiative between REACH, the state TB cell, drug controller office, pharmacy associations, with very clear responsibilities for each stakeholder. And finally, based on the pilot results, there is a scope to involve the whole of the state. So these are our opportunities for scale up, and I think this is something which we have been very, very thrilled that we were able to actually translate what we had been doing for the last 5 years at different levels across the country. So I'd like to thank all of you for this opportunity, and basically to just leave you all with one very, very short incident that there was a patient, Sheba, who was actually diagnosed through a pharmacy referral, and she was so motivated that the pharmacy actually referred her with, because in spite of business interest and losing out the patient, he referred her to appropriate diagnosis and treatment, and she was so motivated that she has actually been a very strong advocate. She goes to the community and has been looking out for patients with symptoms of TB. In fact, in a very short time, 3 months, she's actually referred nearly 20 patients with symptoms, and we've identified 2 patients among them. So such is the commitment of the pharmacy, pharmacist and the pharmacy associations, and I really think it's when we look at private sector engagement, that will not be successful without engaging the private pharmacists. Thank you.
Thank you very much, Ramya. I don't know if anyone has a question for Dr. Ramya or for Pavna. Yep, please come forward.
Not a question. My name is Niranjan. It's more of a remark, and I do hope your project would track the costs of doing all this, because one of the big gaps we found was no one documented the costs of engaging pharmacy, not only the outlets, but also the associations, the zonal, and all the things he was saying.
Yeah.
And
So when we were,
the second comment I wanted to make was also to make sure we track the cost for referral per patient.
When you were actually mentioning that, I was quickly looking at our project. So it was a very small grant actually. We received only $30,000 per year for these, and I'd really like to acknowledge the Lilly MDR TB partnership for this grant, and they have actually invested in several pharmacy initiatives, one of which is Chennai, and so the total grant size for every year was $30,000 US.
Thank
Just
you.
want to make one comment. It seems like a recurring theme that when you ask pharmacists to refer, they always cherry pick a few when they could be doing way more than every single place we do this. They are carefully selecting a few. Even if you give them tons of free vouchers, they again cherry pick a few. So the potential that they could be doing versus what they're achieving